Hello, and welcome to this education and training video associated with the Society of Vascular Surgery's annual meeting. My name is Dr. Jonathan Sheff, and I'm a practicing surgeon here in Denver, Colorado. What I'd like to do over the next few minutes is share some insights I feel like I've taken away from my practice journey over the past several years. Today, my practice is largely focused on minimally invasive anterior spinal access surgical procedures. And as I look back over the past decade since I finished up training, I can't say that I would have necessarily scripted my practice evolution in terms of where I sit today. But I feel like my decision to focus in on these procedures has afforded me an opportunity to really better understand the anterior spine space, not only anatomically, but considering surgical approaches and techniques. And I think also beginning to develop more of a philosophic understanding of approach and utilization of the anterior retroperitoneal space as a whole. So let's spend a couple minutes considering the historic perspective around the anterior spine space. Anterior spine surgery has been around for the better part of the last century, so it's nothing new in that sense. But when I look at how spine surgery has advanced, and a lot of that's been technologic in terms of implants and techniques, etc., there's been this dramatic increase in interest in the anterior spine space. But I still observe a lot of fear and trepidation around the anterior spine space, despite how many surgeons see the value in it. And I see that reaching on a much broader scale beyond just spine surgeons, but to our referring colleagues, our primary care docs, as well as patients. Many of us have heard stories about catastrophic anterior spine procedures. And when you think about them, usually the catastrophe centers on approach-related morbidity or complications. And so I see there being a great opportunity for us to improve the quality of our anterior retroperitoneal spine approaches, and thereby lend to an increase in the overall rate of anterior spine procedures. When you look statistically over the past several decades, there's been a huge uptick in spine procedures as a whole, and while there has been an increase in anterior spine procedures seen, that relative statistical relationship between anterior and posterior still heavily favors posterior. Now, I think there was a real turning point historically in the early 2000s, 2002 to be specific, when Dr. Salvador Brau presented his mini-open approach to retroperitoneal spine exposure. That was presented at the North American Spine Society meeting, so it created a very interesting dynamic right out of the gate to have a vascular colleague presenting on anterior spine exposure at a spine meeting. But beyond just a beautiful technical description of the safe approach to retroperitoneal corridor, I think Dr. Brau really changed some perceptions around anterior spine procedures, showing that with experience and with case volume, these procedures can be done very safely, very reproducibly, with very low complication rates. And so I believe that Dr. Brau set the stage for us really re-engaging with our spine colleagues and furthering the advancement of anterior spine surgery. Now, several years later, we're introduced to lateral procedures and different techniques that have augmented the anterior spine space, but I still don't think those have been a detriment to our contributions on the spinal access surgery side. What then are the issues that really remain in place that limit use of the anterior spine space? I think they all still center around the perceived morbidity. Why do we consider anterior spine procedures morbid? Well, I think traditionally we've used pretty big incisions. I've heard things like go big or go home, or small incision, big mistake, things of that nature that I think have prompted us to feel uncomfortable with decreasing or minimizing our approach to the spine in order to establish a safe corridor, but see what we really need to see. Not necessarily anything beyond that. And that, I believe, is more a philosophic approach to anterior spine access as a whole, because every patient's going to be different. Their body habitus, their vascular relationships to the spine itself. These are all going to change and be variables that we have to account for during our approach. But if we can do that, I believe we can, in turn, really enhance the utilization of the anterior spine space. So when I look critically at my practice over the past few years, as I've shifted my focus onto spinal access surgery, certainly my comfort and my experience in the space has increased. But also, it's allowed me to more critically examine my own reservations in minimizing my approaches to the spine. I see really three key barriers to entry, if you will, in my practice that I believe I had to overcome and at least account for in order to really explore and further my utilization of minimally invasive approaches to the anterior spine. So these three barriers that I see are first and foremost safety. And obviously the buck stops there for all of us. If we compromise safety, there's nothing good that's going to come of that operation in my mind. The second one, though, really has been almost equally impactful to my practice evolution, and that's technological advancements. And what am I speaking of? I'm talking largely about retractor modifications and advances to more spine-specific retractors, but also some technologies that have been around for a while that I kind of think of as repurposed for these specific techniques. And then last but not least, let's talk about comfort and convenience, because I think both of those factors, they're more personal, but they weigh in and contribute to either my ability or lack thereof to perform minimally invasive anterior spinal access cases. So let's talk about safety first. I mean, this really is the fundamental issue in everything that we do. And anytime we even contemplate altering a procedure, such as a technique, or incorporating a new procedure into our practice, I think this has to be the central focus. So what's important to me is to really convey some of the key issues that I see and some of the ways that I've found to improve safety and quality while also working towards that minimally invasive mindset, which is sort of the end game, in my opinion. When you look at safety issues, I think there are a couple key patient factors that need to be accounted for. First and foremost is obesity. It's a big deal, no pun intended, and the obesity epidemic in America today is arguably out of control. And depending on where you practice geographically, you may experience even more so than some of us in other areas. So how do we select patients if obesity is an issue? That to me is a crucial question. The second issue, I think, is vascular relationships to the spine, as well as vascular anomalies. Being able to identify key principles about location and mobilization of critical vessels, as well as taking into account vascular anomalies and adjusting approaches accordingly. With obesity, let's face it, the challenge really is twofold. One, is very fundamental, and that's the absolute skin to spine depth. That's a variable that I simply cannot change, certainly not on the operating table. Maybe with a bariatrician and a consult preoperatively, but there is an absolute point where the body habitus just will not allow for an anterior spine exposure, much like a safe one. And people ask oftentimes about BMI. Is there a cutoff? I think we need to be realistic that BMI is a very loose surrogate for body habitus, right? Because the real issue we're trying to get at here is how does the patient wear their weight? Now, consider also, practically speaking, that as patients' abdominal girth increases, simple math will tell us that our skin incision has to grow to accommodate that. When I start out every case, I localize the disc levels, but I'm very particular about localizing the trajectories to the disc space themselves. So I start out with a lateral fluoroscopic image, and I look at the relative orientation of the skin to the spine, considering skin to spine depth, but also considering trajectory. I mark those levels on the skin, and that becomes, at a minimum, my required incision. As patients are larger, I would recommend extending incision beyond where those disc levels lie on the skin. So if you compare a obese male patient with really dense central adiposity, a really rotund abdomen, so to speak, you can very quickly see that the trajectories to those spine levels at L4, L5, and L5S1, they diverge significantly by the time you get to the skin. So MIS spine exposure in this patient's really off the table in my mind. Whereas some of our female patients who may have similar BMI and may have even similar abdominal girth, but it's that fluffy, soft fat that reforms in the supine position, you may find that the incision is actually very small and very well tolerated relative to their preoperative body habitus. So again, all these factors really have to weigh in on your decision-making process. Now let's shift gears to the real central matter of all of this discussion, which is blood vessel anatomy and the implications in terms of major vascular injury. Okay, I think that as you begin to contemplate minimally invasive approaches, shrinking incision, less tissue trauma, we probably all get some degree of visceral response to that idea because common sense dictates we're working around big blood vessels. Do I really want to limit my exposure to those very blood vessels that may come back and bite me? Probably not. So can I, in a selective manner, identify those patients that are still candidates for a true MIS approach and those patients that may need a slightly larger dissection or exposure to accommodate vascular issues or anomalies? Can we know with confidence going into the operating room where the vessels lie, and can that affect our decision-making process for skin incision size and orientation, etc.? My answer is absolutely yes. And I believe that's really been the game changer in my practice, is utilizing T2-weighted MRI studies, particularly axial cuts in line with the disc space, to give me a very clear understanding of not only a vascular roadmap, if you will, where does the aortic bifurcation lie, where's the iliocaval junction, etc., but also give me insight into the absolute location of the vessels relative to the affected disc space, location of segmentals that may need to be ligated, and also, even furthermore, give me information about the relative ease of mobilization of those critical vascular structures. Now, we're talking about the iliocaval venous system, right? And overlying disc spaces, it tends to become significantly more adherent because of the inflammation that goes along with spine disease as a whole. And so when you look at a T2-weighted MRI, you can tell almost immediately by looking at the retrovascular fat plane or retrovascular fat stripe, which is this whitish line behind the vessel, you can immediately get a sense of how readily you will be able to mobilize that vessel. And again, that to me is put in conjunction with those other pieces of information that we have to achieve a safe, minimally invasive approach to the anterior spine, knowing where my vessels lie and where my sort of pitfalls may lie in that given operation. Using these tools that are already available to you becomes imperative for overall success in MIS anterior spine exposure. Now let's shift gears here and talk some about the technological advancements that I think have really revolutionized my practice and my ability to perform safe, effective, minimally invasive anterior spine exposure procedures. Now what am I talking about here? First and foremost, it's retractor technology. Now I think that's at the core of what we do in the anterior spine space. You really have to have the right retractor to get the job done. My retractor of choice now is the anterior lumbar ring frame made by Thompson Surgical. This retractor system, to me, has really checked all the boxes as far as what my needs are in the operating room. There's this constant fine line we walk, I think, in anterior spine exposure, where we need a balance of rigidity to retract back against myofascial resistive forces. We also need some degree of flexibility, though, and I think that specifically applies to our retractor blades utilized to retract vessels themselves, because it's a different dynamic. We don't want to crank and keep constant tension on a vessel necessarily because of risks of thrombosis and ultimately, I think, risk of tear or injury to the vessel itself. that balancing act is something that I think has been well accounted for in the Thompson ring frame. I think it's translated to better exposures in my practice. But the real game changer to me, what has really augmented my minimally invasive practice and given me a degree of comfort that I simply didn't have before, is the retractor blade advancements that Thompson has released. There's really two sets that work hand in hand and sort of synergistically, if you will. The minimally invasive retractor blades and the advanced minimally invasive vascular retractor blades. Now, the vascular retractor blades simply don't function independently, so I would never suggest you do that. But they certainly can augment in a very, very refined and precise way the standard MIS retractor blades. Now, if we compare the standard retractor blades that have been around for some time, at usually 25 millimeter width renal vein type retractor morphology, to the advanced MIS blades here, you'll immediately note that there's a lot less metal here. So the width of these retractors has been shrunk, not giving up any structural integrity, because again, that goes back to the rigidity piece of the retractor itself. But to me, Thompson's maintained structural integrity of the blade while decreasing the metal by about a third. So when you add that up in an operation where you're using 3 to 4 retractor blades, that also all of a sudden becomes a real advantage in terms of freeing up real estate. Now, why does real estate matter? Well, one, if we're really trying to shrink our incisions and lessen our surrounding soft tissue trauma, it really allows us to shrink our corridor down to what we absolutely need to see. But two, and this relates to our spine colleagues, it frees up real estate in range of motion for instruments being passed in and out of the spine for both prep and then delivery of our implant devices. And I think that freedom of motion comes into play pretty significantly in a lot of these cases. For those of you out there that do a lot of spine exposures in your practice or have experience with this, I imagine you've seen the sort of relative tunnel vision that can occur with a high quality anterior corridor exposure. That tunnel vision, I think, is a complement to the exposure, but in reality, we focus so much in on the spine once that corridor is set. It's easy to forget our surroundings. Not only that, the confines of our surroundings are typically limited by retractor blades. So if you're using 3 25 millimeter retractor blades, much less 4, you have to account for that not only in your skin incision, but your fascial mobilization. And you have to allow for 75 to 100 millimeters of metal to fit into that space without impeding your spine surgeon's operation. Now, if you shrink that metal down like you see here, all of a sudden the ability to work around the retractor blades while still maintaining a safe retraction corridor really augments our spine colleagues' ability to perform their operations. I believe it's really been a game changer, allowing more freedom of movement within the corridor while staying within the confines of the retractor space. Now, add into that, again, as an adjunct, the MIS Advanced Vascular blades. And if you look closely at these blades, they are very, very precisely engineered, especially the distal tip, to an incredibly fine retractor surface that can really augment retraction on the great vessels themselves. I've been in plenty of cases where I truly believe it's the difference of a cell layer between a quality exposure and a major tear in the venous system. Because these vessels can be adherent, they can be oriented in such a way that requires pretty significant but pretty precise retraction as well. Having this very fine distal tip allows very refined retraction on the venous structures at the disc level. And because they're so narrow, they can easily fit within that increased real estate that we just talked about using the standard MIS blades. In addition to retractor technology, which, like I've said, is imperative to successful outcomes and best practices in MIS anterior spine exposure, I've found some technologies that I think I've kind of repurposed for anterior spine surgery that have predated me, but I think add tremendously to your ability to perform these procedures less invasively. One of those is the needle drivers and forceps that I use for any suture ligation or vascular repair. These are repurposed from a mini mitral valve set, and you can see that these are a long, narrow shaft with a Castroviejo type mechanism at the hand level. So what this allows me to do is really keep my hands out of my visual field and still be able to perform any type of suture repair or ligation that I deem necessary in a case. I think bird's eye view of the MIS approach as a whole really centers on understanding that your focus has really honed in this case on segmental spine exposure, but so too has the absolute working space. The ability to kind of fit my hand into the incision and tie down and things of that nature really has become limited knowingly by my approach itself. So I have to account for that, and I think these needle drivers and forceps are an incredibly valuable tool for that. Additionally, I use a standard laparoscopic knot pusher to tie deep in these wounds, again for the same principle. I don't want to obscure my view to these critical structures while I'm working. Now, also in addition to the ring frame retractor, I also am an advocate for handheld retractors that allow an augmented precision to retraction on critical vessels. So I use this Hindi retractor, as we call it, and it's a similar morphology to the MIS Advanced Vascular system in terms of the distal retractor tip. Very fine and allows for very precise retraction of the vessels. And I find that manual retraction in some of the tougher cases allows me to constantly augment retraction on these critical structures and sort of adapt my exposure as the spine portion of the procedure progresses. Finally, this is another repurposing move. The Alexis wound protector is something that I use in every one of my MIS anterior cases. I like the fact that it's very simple, easy to use, relatively cheap, but what I use it for primarily is to, one, sort of compress the soft tissues down and make the wound more manageable, but two, as the title implies, to protect the wound itself. I put 2 moist laparotomy pads surrounding the wound before I insert my Alexis wound protector, and that keeps the wound nice and moist, keeps it from desiccating, and I find that the wound closures cosmetically are much more appealing when I've had a moisture sort of barrier interface throughout the procedure. Additionally, when we're passing instruments in and out of the wound, both for the MIS exposure as well as the spine portion of the procedure, you'll find that the wound protector kind of keeps those tissues nice, tight, and out of the way. And I think it protects them from injury as those instruments pass in and out. I think we all have to just be aware of our own limitations as we're doing procedures and evolving our practice. And from a comfort standpoint, I think that directly equates to experience. Out of the gate, I think we're all relatively uncomfortable, even in our training experience and then our early practice. We all realize that we're working around big vessels. We're working with another surgeon to try to accommodate their interests. And so it makes sense that our own comfort translates to the relative, I'd say, quality of our work and then sort of that minimally invasive component of it. Now, the convenience factor is also very real, and I think I have to take that into consideration every case, right? Because to the degree that a small incision and less soft tissue mobilization causes us to struggle a little bit, it really fights or flies in the face of convenience itself. Now, from my standpoint, I've gone so far as to say if I'm not struggling just a little bit in an operation, then my incision is too big. Now, I get that that's probably an extreme deviation from what we talked about earlier and traditional open type anterior retroperitoneal approaches, but I think having that mindset has forced me out of that comfort zone and really lent itself to reducing incisions in a very precise manner, patient to patient. And so over the course of time, I think having that focus centrally, sort of at your core of your practice, will enable you to shrink those incisions down and begin to pare down that surrounding soft tissue trauma to land at a point where you do feel comfortable, you feel safe, but it may not be as convenient as a bigger incision, but I believe it's going to translate to a better patient outcome when it's all said and done. At the end of the day, really to me the key takeaways here are we have to understand our own limitations and our own barriers to entry to the MIS space before we can possibly endeavor to evolve our own surgical techniques and practices to accommodate less morbid anterior spine exposure procedures. I wouldn't suggest that you ever push yourself so far out of your comfort zone that you compromise safety. That to me is a non-starter. But I do think consciously edging towards the extent of our comfort zone is going to allow us to constantly advance our technique as we become more comfortable in the anterior retroperitoneal space. Now, how do we bridge the experience gap? Again, I think recognizing technical limitations with relation to patient body habitus, past surgical history, etc., and also really honing in on a better dynamic understanding of patient-specific vascular anatomy and how that's going to impact on the surgical approach itself. There's nothing quite like knowing that you're walking into a den of lions ahead of time versus being surprised when you turn around and you see them staring you in the eye, right? So with that said, I think the technological advancements that exist, and also, like I said, repurposing some technologies that already were there to afford a more controlled MIS corridor to the spine is key to the ultimate safety and success of your operation. I want to thank you again for your time in viewing this video, and hopefully it adds some value to your practice and your journey as a whole. Thank you again.